for everybody who's joining us for the first time. This is a Conversations in Global Health, which is a one-credit course that we also make each of the individual sessions available to the Georgetown community. And the purpose of our of the conversations is to find a leader, to engage with a leader in global health, talk to that person about his or her career, and then turn to some topical questions of the day. The format we'll use is that I'll start with about 15-20 minutes of questions with our guest. And then I will turn to the students who are enrolled in our class, and 3 of them I've already queued up for questions, and we'll open up to the students of the class. And then with the time we have left, we'll open it up to the larger community on the Zoom call. And tonight, I cannot tell you how delighted I am with our guest. Our guest, Dr. Eric Goosby, is a longtime friend. We first worked together probably, that's getting close to 30 years ago, Eric. So it's terrific to have you here. You know, I think, as you all know from the bio, whether you participate, whether you're in the class or you got the notice, there are few people in American public health with the kind of background that Dr. Goosby has. His service in response to the HIV/AIDS epidemic in our country and around the world really is without peer. So we're really excited to have him here tonight and to share with us some of his thoughts. And so with that, I think if you're okay, Eric, I'd like to just start off at the beginning. And this, before we jump into today's issues around COVID or HIV, we always like to start these with asking our guests to reflect on where you were when you were in their shoes. So maybe you could tell us a little bit about when you were an undergrad, what made you interested? Were you thinking about a career in medicine, a career in science? And then maybe tell us a little bit about your path that got you to medical school. Because I think, you know, we always learn a lot about where people come from when we think about where they've ended up. So maybe you could start off and tell us a little bit about where you started.
Okay, well, sure, John. It's always a pleasure to talk to you, but I'm really happy to have an opportunity to talk to your student. I was born and raised in San Francisco. My parents were as well, and it was a life that was the only one we knew, so we weren't comparing it to anything in the way of politics. But my parents were very socially aware of kind of where the dialogue was around civil rights issues, and my older brother went to Berkeley in 1966 and was intensely involved in a lot of the free speech movement, and then later the civil rights movement, especially kind of on the Black Panther Party side of the continuum. And just in terms of who were the people he was in class with and in his household. So we were, as a family, involved in a lot of the political activity because of the proximity. Right. And my high school was right in the middle of the Haight-Ashbury in San Francisco, St. Ignatius High School. And it was physically in the Haight. And that bubbled up underneath us. So it was an eclectic exposure to a lot of ideas at a time of a lot of kind of reconciliation. And I think that framed a face forward to social issues, and medicine kind of became a consensus activity in that kind of a portfolio of different interests and influences. I went to Princeton University undergrad, had a science orientation coming into it. My interest in that university was mainly in their sciences. And it was my sophomore year that I was in what was a program called the Big Brother program, where you would adopt for a 4-year period a child in an orphanage in Trenton, New Jersey, and you would basically be their tutor for all of their coursework, do homework with them, and that young man he was 9 years old, developed a headache, a fever, and became semi-comatose during our homework session. And we rushed him to the emergency room. He turned out to have meningitis, and I saw the emergency room jump into their performance. And that was pretty much the moment that I knew I wanted to go into medicine. I was thinking environmental biology, specifically marine biology, because I had a lot of interest in high school around that, and lived in an area where it was rich. But that event in Trenton, New Jersey, I never pretty much looked back after that. Went straight forward. So that's kind of how the inclination.
Well, life presents itself. Then you ended up going back to California, though, right? To UCSF.
Yeah. So went to school, undergrad on the East Coast, then went back for medical school to San Francisco, to UC San Francisco, and stayed there for medical school, residency, internship, fellowship, and stayed on as the faculty. During that time, in the late 70s, early 80s, HIV bubbled up in the community that our hospitals and clinics were in the catchment area for. And that out of being there at that time put me right in front of a lot of preliminary descriptions of HIV, how it moves through an individual and attacks their immune function, what kind of opportunistic infections they have, and that was a big area of interest. But then it evolved into antiretroviral discovery, and much of that first decade was setting up an AIDS clinic at an outpatient level that was AIDS dedicated, and an inpatient clinic with Paul Volberdine and Connie Wolfsey. And there were about 6 of us who were there at the beginning of that effort. And each kind of academic medical center on the coasts were going through similar evolutions. And we all kind of professionally grew up together. And that's when I first started interacting with Tony, another common friend of John and I, Tony Fauci.
Yeah.
Everybody sees on TV now.
Yeah.
But he was in that same position initially at Cornell for a few years, but then in the early 80s went into NIH as the director of that institute. So he kind of orchestrated the federal research that went on in those early years.
Eric, I know this is hard, but my recollection of our conversations of your early years, those were tough years to see patients, both of the outpatient and inpatient setting, right? Because no one was recovering, right?
Yeah, John, the 100% fatality rate. It took over a decade to get there. From infection to first symptoms was in the United States often a decade long. In countries where nutrition and immune function is more depleted, just in general in the population, you can have a inoculation to first symptoms of 3 years in sub-Saharan Africa, India. But that same disease in a nutritionally replete person takes a decade to wear down to the point where they're susceptible to opportunistic infections, but uniformly 100% fatal. So everybody who was infected eventually ended up succumbing to the infection. And that put a fear in the early response from the healthcare system's perspective, not understanding how the disease was spread. As with COVID,
Yep.
and you see what an aerosolized spread looks like. In the first 3 years of HIV, we thought that it was spread by aerosolization, which is a much more aggressive, rapid movement through the population. And you now have seen that with COVID. But for HIV, it would take 10, 15 years to have the cohort of individuals who were infected in the same kind of period to start presenting to emergency rooms and hospitals. That kind of delay made it a much different epidemic.
And absolutely, and I guess the one when we first met, when you were running the Ryan White program, we had moved in HIV from having no treatment to having the beginnings of what has now turned out to be incredibly successful ARVs. It must have, I mean, I guess if you could say a little bit about, obviously the difference between COVID and HIV is different for all the reasons you identified, but we're also kind of at a moment now where the vaccine is playing a role in COVID that's similar to the ARVs did. We've gone from a no hope to a real hope setting. And I guess maybe just sort of personal reflections on what you remember, what might be applicable from the HIV experience to what we're going through now with COVID.
Yeah, I think HIV primed the delivery system, the hospitals and clinics that make up the delivery system, whether it's private or public. It primed them to appreciate the importance of engaging the community in which these hospitals and clinics reside as separate population targets for identifying individuals initially for COVID testing and later for vaccination. For HIV, the testing period stayed for 15 years, where our primary intervention from 1980 really until 1994 was preventative, trying to prevent exposure and transmission. Once you got it, we were able to slow things down, but it wasn't until but eventually you would succumb to the infection and the opportunistic infections that took over. And then in '89, the first antiretrovirals were discovered. They were discovered in San Francisco and New York. And they were good in adding about 18 months of life to an individual once started. And it wasn't until 1994, 5-6 years later, that we discovered highly active antiretrovirals that actually stopped progression of the disease in the individual that took it. But we couldn't do it with just one antiretroviral. We had to learn through, really empiric observation, just seeing if it worked better, adding 2 and then 3 drugs to the cocktail when we started treatment effectively prevented the escape virus mutations that we're seeing with COVID, because we had 2 or 3 drugs in front of it, so it couldn't replicate. So we blocked replication even if it mutated. So a longer story, but we're going the same things with COVID. So the parallels are complete. It's just COVID does it in a time frame that's days to weeks, that for HIV was years. But the same challenges, the same implementation needs, the same populations disproportionately impacted are repeating itself with COVID, just as they did with HIV.
Before I turn it to our students to start their questions, I guess one thing that's striking to me about what you described about the parallels between COVID and HIV, but also the fact that you work both in the US and you described the difference between the disease, the HIV in the US versus how it appears, particularly in low income or low resource settings where people's immune systems are compromised. But it does seem to me that one of the things HIV taught us was to think of social justice and how infectious disease impacts us both in our domestic community within the United States, but also global justice. Because of course, when you were the leader of the PEPFAR program and your work on TB, you focused on the global burden of disease. And I guess we're at a big debate now about should vaccines go, how do we decide, do vaccines go to, should wealthy countries have the first access to treatment? How do we think about equitable access and social justice? And so maybe before I turn it over, if you might reflect a little bit on what we learned from maybe the hard way about injustice from infectious disease, but then also what we need to think about in terms of treatment and what that means about our obligations morally.
Yeah, well, John, that's your sweet spot. You have always kept that theme in your life since the first time I met you. But it's the correct theme. I think HIV did show us, as I think really all diseases do, it doesn't move through populations and societies in the same way at the same rate. It doesn't have the same access and exit points. The socioeconomics, the cultural milieu inform, alter, and change those opportunities for a virus to replicate more efficiently, more effectively, moving through the population in a shorter period of time, reaching populations that may not have been reached in a less creative or nimble virus. And understanding how that virus moves through an individual is kind of the medical end of the continuum, but how that virus moves through the population brings in all the social determinants of where a person is positioned in society, and that should inform how medical delivery systems build themselves to identify, enter, and retain those individuals who, for a variety of reasons, have barriers to access and retention. And it is a social justice issue. It's one where a medical problem meets law and societal norms and practices, and it's a political solution that usually moves the agenda forward. So it's a great example, John.
Eric, thank you. And so, as I mentioned to you, what we do is we'll now turn questions over to the students that are enrolled in the class, and 3 of our students have prepared questions in advance. So I'm gonna start with Kent. So just and let Abby and Yunma know that you're in queue afterwards. So how about we? So Kent, do you want to kick us off? Nice.
Yeah. So
excellent. Thank you.
Thank you so much for speaking with us. One of my questions was, so there was a recent CDC report about LGBTQ plus people facing a higher COVID risk associated with underlying conditions. So kind of what did you learn about the LGBTQ plus community during the AIDS crisis? And then what are you seeing now during the pandemic? And then just in general, how can public health interventions better help this community? And I'll post this in the chat also.
Okay. Well, that's a great question, Kent. Really, a lot of insight involved in that, in asking that question. For HIV and for any disease, LGBTQ populations' first instinct is not to engage and reveal themselves to the medical delivery system for a diagnosis. It's a high threshold to be reached in the gay community in the United States, but even more so in other countries, and we can talk about the reasons for that. But it is in part from growing and maturing as a individual in your own self-awareness and awareness of your gayness, and how you relate and present yourself to your family, your friends, your community, your workplace. All of those are separate and additive hurdles for a gay person to decide to come out in our society, each having real consequences that are more good in the long run than bad. But it took 20 years for gay communities to really build up the resilience to push that agenda forward. That same inertia is present with revealing oneself for a COVID test, and in many instances for going ahead with the vaccination, as John is saying, is very much like a treatment in this instance. But I think that creating the need to understand kind of that psychology, if I could use that term, and the need to create safe spaces for people who have consequences in coming forward to be diagnosed or treated for any disease, need to also know that that space is protected and will not domino consequences in areas of their life that they are more vulnerable in, more fearful of, or just don't want to have transgressed.
Eric, thank you. That's great. That's terrific. And I'll turn it to Abby next.
Yeah, thank you so much for speaking with us today. I really liked learning about the President's Emergency Plan for AIDS Relief and your role in the implementation of that. So one of my questions was that when I was researching PEPFAR, it was shown that the greatest potential for HIV/AIDS relief is in countries such as Botswana, Kenya, Malawi, and many other low and middle income countries. How has a lack of digital technologies in these regions impacted the expansion and posture of PEPFAR? And I'll also put my question in the chat.
Well, that's a great one, Abby. Thank you for that. Botswana, in the early awareness of HIV on the planet, became a country that was identified as having up to 36% of the population infected, a prevalence rate of 36%. It's a tiny country of less than 2 million people, so that is what it is. But it nevertheless got the distinction of being the most heavily impacted country. And because of a relationship with, is it De Beers Diamonds? De Beers? What is the name of that?
De Beers, yes.
Diamond company being rooted in the country, there was a motor resource for money to stand up an early interest that came together with Harvard and Merck pharmaceutical company to put the first treatment capability on the continent in place at a scale that wasn't just one or two clinics, that wasn't one hospital. And they targeted Botswana to do that, and took it through the evolution that you're asking your question about, which was a relatively unsophisticated capability and response to HIV in a medical delivery system that was capable of strengthening significantly as it was, and had the kind of support from Harvard and Merck to ratchet up what became the development of a medical school, a school of public health, became the Southern Training Center for HIV docs, as did Uganda for the kind of Eastern African Training Center. That really made a huge difference in bringing the region along with competent, trained, evidence-based decision-making and treatments. So it taught me, Abby, that there really isn't a place that you can't start to strengthen a response into any disease, and the importance of using Botswanan ministries of health, clinics and hospitals and their education system to build a medical school and a school of public health gave the country a capacity that's still giving. So I would say that too. It's a different learning curve, but one that still works.
Excellent, Abby. And then how about Yudma? And then we'll open it up to the rest of the class. Yudma?
Thank you for coming to speak to us. And my question is in regards to the pre-reading of the Lancet Commission's article, where it stated that ending tuberculosis must be framed within a broader health and development agenda. And so considering your role as the UN Special Envoy on tuberculosis, what strategies have been developed to sort of shift the agenda from one that's simply health focused to one that considers other social drivers of tuberculosis? And how can we also apply this to COVID-19?
Yeah, the real frustration has been, Emma, that countries are not in a position where their population holds them accountable for delivering healthcare. So it's really hard for a donor country to come in and clap and scream about the need for you to engage in your population with HIV or COVID. In a country where they haven't prioritized healthcare, where diabetes, hypertension, and coronary artery disease go undiagnosed and untreated. People dying in their late 40s to early 60s as the routine and accepted state of the kind of humanity. And if there isn't more of an appreciation demand coming from the population, it's not going to really change. So, and I could say that about areas in San Francisco or Washington, D.C. Okay, that same dynamic plays out everywhere. It is time for the medical community and I think society to say that healthcare and education are what we mean when we talk about an equal playing field. And for people to be competitive, governments, societies need to deliver that to the population so everyone can kind of go competitively after it. And I would argue, even if we say we're approaching an equal playing field, the inequities in nuclear families and kind of the help I had in homework as a elementary school student was very different than many kids who are in southeast part of DC or in Baltimore, where that isn't even in the family's consciousness as something they're not doing. Okay, so where is that child's peak level going to be? Heavily influenced by that lack of support, which is kind of a counterfactual and is hard to model against or understand. And it's easy for society to not engage on this problem. So for me, social sciences and the medical sciences have got to understand how the populations are different depending on the disease, how it manifests differently, how they benefit from the science we already know to diagnose and to benefit from the treatments, and that we need to follow those disparities as we better understand the maturation and growth of our society. And I hope that the Biden-Harris administration is talking about this for as kind of the destination of what they mean by focusing on the middle class and bringing opportunity and resource to populations who historically have not had it. There's also a legal component to that and an economic component to that for the first time in my life, they're talking about all at the same time. So the opportunity to bring social determinants into the discussion, as the UN has tried to do since 2015, unsuccessfully, is going to be realized through a kind of a popular movement that arises out of the population, the people who need and use and depend on the health services. It has to be demanded, and politicians need to be held accountable for it. It's very hard to do in a multilateral, bilateral lever. John spent a lot of his time trying to take the example of institutions that are reflective of a shared responsibility, like the Global Fund for HIV, TB, and Malaria. Three-quarters of the countries contribute to it. It's there for poor, low, middle income countries, but low economic countries that will never be able to advance on the diagnosis and treatment of HIV, TB, and malaria without that kind of help. How do you do that equitably, fairly? How does it go to the most in need? Should it go to the most in need? What do you do as countries engage with economic growth? How do you not supplant their domestic investment with your multilateral or donor investment? John can speak to any one of those issues for hours and hours, but that's
well, I won't. That's why. But you're here today, not me. So exactly, they get to listen to me whenever they want to. Though.
Yeah. Okay. All right.
But no. But Eric, let me. No. I want to follow up because I think I think when Yunma's question spoke to the Lancet Commission on TB laid out a terrific global agenda. You work with the Secretary General and move that issue higher up on the global diplomatic agenda, no question. But at the end of the day, it does seem that we need a movement, not in both in the United States, but also in countries around the world, to hold governments accountable. If we want countries to invest in TB, there has to, on some level, be a call from within those countries. And so I know you're working around the world. I guess one thought is, do you think COVID is getting us closer to the place where that political will exists in more countries, or do you think it's a setback from building that agenda in the countries that you work in?
Yeah, no, that's the perfect question, because I think COVID did open a real window of opportunity. And I think the United States, is in the best position. And I guess I would say it this way: other countries would give the United States license to play the role of using COVID as a rebooting of kind of the social determinants discussion in the context of the big killer diseases and an equitable availability of diagnostic and treatment responses, to actually start talking about how do we measure and understand whose delivery systems are delivering to the population's needs and whose aren't, and what, if any, is there a shared responsibility in trying to move toward the mean in all 193 countries on the planet, a kind of basement of healthcare delivery, basic primary care, maternal and child health, reproductive health, family planning services available. And is that, so I believe that we are at a moment, because of COVID, where a reconvening of that conversation, which has happened 100 to 1,000 times in bits and pieces over many years, can be accordioned into a time and place that actually moves the agenda. Just as COVID accordioned the natural history of what HIV was, everything happened the same as it does with every virus, but it just happened in a much shorter time frame. I think it would be my hope that the COVID moment, if the US takes advantage of it, can sprint into a unique but constructive discussion, a global discussion that actually begins to hold ourselves accountable for disparities within, on the planet in the ability to deliver healthcare. A very difficult discussion. I'm not naive about it, but it sure is needed.
Absolutely. So let me see if there are other students in the class who've got questions. Why don't you just raise your hand? We've got a little bit bigger crowd here tonight. Anybody? It looks like I've got Kayla's. Looks like she's got her hand up. So why don't I turn to her? Kayla?
Hi, Dr. Goosby. Thank you so much for coming to speak. I'm also a San Franciscan, so it's nice to have someone from the West Coast here. My question was kind of more broadly related to patent protection of certain antiretrovirals and how the global community can make drugs more accessible to low and middle income countries, how we can circumvent or work around these patent protections that have historically made these really necessary and valuable drugs so inaccessible to the countries that need them most.
Yeah, a frustrating problem that is present in our country and every developed country, but also much worse in developing settings. There are examples where companies have made their molecules available. Tenofovir is an antiretroviral that replaced a effective antiretroviral that was ubiquitous in sub-Saharan Africa, D4T, in 2003 until about 2011, was used in every regimen on the continent. It caused severe peripheral neuropathies, so much so that some people committed suicide because they couldn't endure it. Permanent burning, numbness, and tingling in your feet was the usual setting for it. And some with chronic boring abdominal pain that dominated their lives. So we were able, with the company Gilead that made tenofovir, which was the drug used in the developed world, had no side effects. People didn't even know they were on it, as the backbone for the treatment in sub-Saharan Africa, which had 75% of the people who are HIV positive on the planet. Still does. So the idea was that Gilead made the chemistry known to Serum Institute in India, who manufactured a generic form of the drug that Gilead got 1 penny for, and that was enough to cover the costs of manufacturing and to make the Serum Institute happy in terms of a profit. So we were able to shift a drug that was not available without you purchasing it in Europe or the United States and then bringing it by suitcase into a country that hadn't approved it yet, and going that route. That's an example of it is doable. The problem is that you can't name other pharmaceutical companies who have gone that route with a cash producing drug. And we live in a society where most of the pharmaceutical companies are in countries where they're protected with, as you say, patent protection. And we act like we aren't smart enough to figure out how to protect and preserve R&D reimbursement and profit, and still make the drugs available to countries that will never have the resources of a developed setting to pay for them. And the reason we do that is all of the kind of lobbying and political support favors the kind of unbridled expansion of a company's ability to expand a profit margin as much as the market will tolerate. And pharmaceutical companies really are in that mode of thinking. So I think until people once again demand that enough is enough, We know we're smart enough to figure out how to get a drug making capability that is not just driven by profit to shareholders as the only motivator. There are orphan drugs, pediatric formulations. We have known identified cures for diseases that don't affect large numbers of people, that pharmaceutical companies have elected on a business model plan analysis not to invest in. And there you go. So, I mean, we're way down the road in a world that ignores and has a blind eye to not taking advantage of those opportunities. We don't ask a drug company to study pediatric dosing formulations for any drugs. So antibiotics, a good example, you're going to use them in kids, but a pediatrician has to extrapolate and experiment empirically by just giving the kid a fraction of the dose that you'd give an adult. The milligram per kilogram dosing regimen does not take into account the physiologic differences in kids and adults. They're generally not super important, but sometimes they are. And to not have figured that out just is an economic decision. It's not that we don't know the science to do it.
Excellent. Great. Thank you. Let me see if there are any other questions in the class. If not, I'll then just, I do. Okay. I got a list here. I've got, let me sure. I got Shoah, and I've got, looks like Shoah and Erica. So why don't we start? Shoah, why don't you go first?
Yeah, I just want to start off by saying thank you for coming by and speaking with us. I watched a documentary a few months ago about HIV/AIDS activism and how that was able to initiate the start of the fast track designation at the FDA. And that was, of course, something that impacted COVID-19 research and development. But I was wondering if you could speak a little bit about the benefits and drawbacks that this precedent for developing, approving, and then manufacturing a vaccine could have moving forward.
Oh, great question, Shoah. What we've seen with both the Pfizer and the Moderna vaccine and the AstraZeneca as well is a teeing up of phase 1, phase 2, phase 3 study protocols before you had a product. And the way drug approval goes is you do the phase 1 study when you've got the drug to do it on, right? You don't just set up and start collecting people. So as soon as you get a drug, you throw it into the mix and you are already fully enrolled. You run everybody starts on day 1, and you're able to take numbers of people through studies. So the Pfizer study looked at 40,000 people. 20,000 got vaccine, 20,000 got placebo, and followed them and was able in real time to see in 7 days a divergence of people who got the vaccine did not contract, become positive with COVID. They were able to see that after 7 days, and then just follow those curves out. My point I'm trying to make is that the numbers used for phase 1, phase 2, and especially for phase 3 were 3 or 4 times larger than any other vaccine studies we've ever done. So the data and confidence that we have in, are we really seeing real effects that are showing efficacy, or are we seeing some aberration of having cut corners? Well, there were no corners cut. There were more numbers used in these studies than ever were used in any prior vaccine studies. So our confidence is actually higher with these rapidly determined in a year vaccines. And we're going to get 2 more very quickly here that came out of a similar approach. So it's an understatement to think that this isn't going to revolutionize drug discovery across the board, not just with vaccines. The problem is you have to have a huge capital to invest on the front end. The Moderna vaccine, NIAID, Tony Fauci put $508 million into that on day one for development, gave it to them. That doesn't happen. A private company has to get private investors to approach that, and they would give a fraction of that amount to launch a phase 2, phase 3 study. It wouldn't be anywhere near that. So my point is that it definitely is going to change it, and for the better.
Great question, Shoa. Erica?
Hi, Dr. Goosby. Thank you for speaking with us. And I was wondering, you mentioned healthcare, how healthcare and education go hand in hand. And I understand how this idea is very central to addressing the social determinants of COVID-19 as well as HIV. I was wondering, what can institutions or everyday people like us can do to dispel implicit bias within medical centers, as well as increase sensitivity and awareness around race and bias, particularly in communities where this implicit bias is already so integrated and normalized?
Wow. Gee, if I figured that out, we're going to be in great shape. But it's the question, it's always been the question in our country, and continues to be urgent and emergent. So I thank you for asking it. I don't know the answer to it. I do know it falls along the lines of, from a kind of institutional perspective involved in education, to prime your students to understand what's happening, so they continue to see the continuation of disparities that have not been addressed. So the surveillance component to keeping it in front of people is critical. In countries that don't keep track of it, they don't talk about it, politicians don't get called on it, and nothing happens. So I do understand the relationship between being able to count it, talk about it, so you can change it and know you changed it. But I would say that that the willingness to engage in that as a kind of a society is very low. But Erica, did you ask a specific question about that? Was there a specific question that came in? I've lost my train of thought.
Yeah, I guess, one of the questions was, what can institutions or just everyday people like us do to, increase awareness?
The reason I forgot that is because I don't really have an answer for that. The institutions have to be held accountable. And it's hard for a student to hold your institution accountable, but it's not hard for you to create a discussion about it. So you indirectly are tweaking the system to reflect itself around those issues. I think faculty have a specific role that's different than the students along the same lines. And leadership within faculty need to ask themselves, is it important to understand the reason that certain genders and racial groups are consistently excluded from faculty and leadership positions and student enrollment? And is that something we as an institution want to monitor, talk about, and understand? Not at one point in time and get it out of our system and we've done what we needed to do, but continuously, because the change that's needed for that is continuous, and right now and in the future, and it intersects with the institution's self-perception of how they recruit and hire their faculty and their students. So you've got to just know that that's where you're starting from, and you have to mesh that discussion. So I think the approach is to keep the disparities on the plate without it being an argument. So getting it institutionalized, that you follow the number of women professors, at the assistant, associate, and full professor level? Who goes on to the, the level 6 level within the full professor level? Who are your emeritus professors? That tells you really most everything about your institution. I mean, it's where they invest and where they keep investing, and then you have an honest discussion about it. And it is like moving an aircraft carrier to change it, but having the discussion is kind of a victory in and of itself. So iterative, persistent.
And I would just add, Erica, the world didn't end up the way it is by accident, right? And it's only by people calling the question over and over again, particularly to people who benefited from this system. Put myself clearly in that category. These can be uncomfortable conversations, but the conversation won't start unless people raise their voice. So that's, and we're having a moment in this country. I hope it doesn't stop. That's my biggest fear, is that we've had moments before that have passed. We need to keep on. Let me turn to Valen, if I could. If you maybe, and then we'll have hopefully time for at least one question from the larger group. So Valen.
Hi, Dr. Goosby. I'm wondering, so you mentioned in developing countries, resource distribution inequality and like the stigma against marginalized populations are often even greater than the United States. And I'm thinking that one of the consequences of like the ensuing sort of lack of transparency could be perhaps that there's more there's like a lack of data or information of the population. So to what extent does the UN work with domestic organizations in low-income countries where I guess surveillance capacities can be weaker than developed nations to gain more comprehensive data, to use in its intervention efforts, and while doing so without sustaining this sort of global health's colonial roots?
Yeah, that's a good one. I think the ability for a community to hold the conversation is what I've seen be the most difficult part of it. And as you move into some marginalized populations, the consequences of revealing yourself can be very different. In Uganda, the criminalization of sodomy to a capital crime was put forward in the legislature, and that kind of feeling being widespread within the legislative politicians. So they're catering to their constituencies by just raising it, not really expecting it to get passed. Having those moments engaged with are critical and important to find a voice that's in the government, somebody like the president speaking to the legislature or the judicial branch, but it's having the community figure out a way to concretize a way to carry that dialogue forward, and that is usually where the conversation is blunted. People, it moves into personal safety for families, and there's no protective response to a transgression. So it's tricky, and it's worth another discussion probably as to kind of how to think through it. John and I were involved in that discussion in Uganda and Tanzania when it occurred around HIV and homosexuality. But I don't have a real answer that I've seen work consistently.
It's a very tricky situation. So let me try, Eric, we know we're getting close to the end of your time. So I've got Lydia has, so I'd like to propose Lydia as a question, and then we'll, if you can stick with us a couple more minutes, open up one to the question to the larger audience, if that's okay too. So Lydia, would you go and maybe a brief question if you could?
Yes, I'll try my best. And thank you so much, Dr. Goosby, for coming to talk to us. But my question is about, since AIDS, like COVID, was a disease that had a lot of misinformation surrounding it. And you talked about how you went through the process of like when you were first treating AIDS patients, you guys didn't know, or doctors didn't know how it was transmitted. So I'm wondering if you learned anything from that about how to communicate new information about a disease, because as scientists are discovering it and trying to convey to the public how new discoveries happen and new information is gained while combating misinformation about a disease.
Yeah, you bring up a real challenge to everybody. As you've pointed out, we didn't know this virus existed in January of 2020. It was January 10th that the genome was made available by the Virology Institute in Wuhan. And that was as quick as any virus has been revealed to the scientific community in the history of virology. You discover a virus that you don't turn right around and give it to the world, the genome for it. They were the first to do that, just to make the point, which was what started all of the vaccine work, and without which we would not have had any vaccine work. So I think that is something that should be an example of how the international health regulation works in countries where there's an outbreak, that it convenes a response that can only be strengthened by involvement of multilateral and other countries, and that needs to be worked out. I think that that the extraordinary scramble with knowledge, I'm still kind of breathless looking at what happened with COVID. What happened in over a 15, 20-year period in our understanding of the natural history and pathophysiology of HIV happened in months with COVID. And to a large degree, it's because the people who did it were all the people who did HIV and knew right where they had to go to define what it's doing to the immune system, BT cells, natural killer cells, how that works on mapping it, how that feeds our diagnostic test capability, and how we identify outcomes that we look at to see if our treatments work. We knew how to do that in our sleep. That would have had to have been figured out if we didn't have the example of HIV and the people in place to just put a new virus in the machine. And so you're seeing science at its truly remarkable best with what COVID, the challenge COVID presented and the response to it.
So I think I'll open up for, I hate to do this, Bill, just one question from the larger audience. So if anybody's got one, I think I know at least one. Panaki, I think you win the lottery, because I think you're the only one that I can see right now. So if you want to jump in, please do.
Thank you, Dr. Goosby. My question is around, we started talking about it here in the last hour, and comparing COVID-19 with HIV and global health. And what I have seen doing some global health over the years is when there is a need in the developing world, and United States can act as a leader, and whether as a donor country or bringing science and technology, that brings a lot of clout and a lot of power to do global health and immediate help to the community. In COVID-19, what I see is it's kind of the other way around. Like all the developing countries, they have much lower disease severity and death. And I think it is kind of no solid data, but I think there is a lot to learn from developing countries, why their immune system is, whether it is due to BCG or due to malaria or other infections that have long-standing different types of immune response, which provides protective immunity against COVID-19. So we can learn a lot if we have the ability, the same type of leadership that we had through PEPFAR, to learn about this disease more. But under the current circumstance, when the deaths are much lower and the disease severity is much lower, I don't think we have a chance to really learn from that population. So how do you compare and contrast, and what should we do now? At least we are in a good position politically to gain back our leadership role. What do you think? How can we use, I don't want to use the term use or exploit, but take advantage of the COVID scenario and reestablish our role as global health leaders or leader?
I think it is that opportunity, and I think that Biden-Harris administration, and John's been involved in these discussions, has that in their sights, as this is that moment and the opportunity is real. I just want to make sure people understand that a lot of the lack of case expansion in sub-Saharan Africa that the first 9 months really reflected, hardly any activity, just really at airport nubs, which is what we saw in the developed world. That's how this thing spread. So countries like South Africa, like Nigeria, like Kenya, that have an active hub of airport activity, that's where COVID started, and that's where it spread from. That's where it's continuing to spread. And that in these settings where there's no vaccination going on, as a new variant presents itself, as it's done in South Africa, you have a much more efficient ability to infect people with the same exposure, so efficient at infecting. But it's also, because of that, infecting more people are getting symptomatic, more people are becoming hospitalized, and more people are going to the ICU, and more people are dying. So it mass actions more death, but it's about a 3-week delay. But we're seeing that in Cape Town, in places that keep records, we're seeing it. In places that don't, it's still going on, we're just not documenting it. South Africa is way ahead of most of the continent in terms of surveillance. So I say that to just, I think we have yet to see how it will move through sub-Saharan Africa. It's going to be slower, but it still has the same ability to spread if given the opportunity. So the need to get vaccinations into sub-Saharan Africa for the planet's health, and not to foster more rapid emergence of variants. We need to vaccinate the planet. And that is an imperative that developed countries now need to take the leadership role in. And just as you've implied, the United States is positioned to be that convener of those discussions, to support the COVAX activity for Gavi to buy a vaccine and make that at least one conduit to bring vaccines to low-income, countries. And but we're going to need more, and to look at what we're going to do with all the excessive vaccine purchases that we've already made in the United States and in Europe. If everybody comes through with what we've already bought, we're going to be giving a lot of vaccine away, and we should do that responsibly, transparently, with an eye to those most in need, and an eye to variant propagation, the propagation of variants. So,
well, Eric, that is a great way to end this. Well, thank you for staying longer, and as always, your life's journey and your work is a real message to all of us. So we're really grateful. So I made a round of Zoom applause for you, and we are very grateful.
Thanks, John.
Thank you for joining us. So what we'll do now is, Eric, we'll let you go back to your regular life. And I would say anyone who's not enrolled in the class, you're welcome to exit the Zoom. and the class will have, we'll take a few more minutes to wrap up. So thank you. Thanks, Eric.